Oh my God.
Good evening.
meeting good evening, one and all. Welcome to our Thrissur IAP clinical meet. So now virtual meetings, virtual.
Madam, please unmute yourself, unmute and talk.
Now am I hearing?
Yes,
Can you hear me?
Right.
Okay. So good evening to one and all. Welcome to our monthly meet today. Nowadays, it is the virtual meetings are the rules of the day. So from now on, every first Tuesday of the month, I expect all our members to join us for the monthly meet. Okay. So last week we celebrated our ORS week with much gusto and vigor, and we concluded the meet with a beautiful ORS video. And I thank all the participants of Thrissur IAP who pitched in with their activities. We have started now the breastfeeding week. Yesterday we had two beautiful talks by Dr. Manoj from Jubilee and Dr. Febi from Government Medical College. It was very nice. And tomorrow we have an excellent panel discussion coming up. So members, please do join in. I request our Vice President, Dr. Sunil, to give the welcome speech.
Thank you, Dr. Reddy. Audible?
Yes.
Thank you, Dr. Reddy. As always, it's a lot of happiness and great pleasure to be back for the webinar and to see all of you, my teachers, senior IAP members, and friends of IAP Thrissur branch. So let me do my duty. First of all, I wish to welcome our ever-loving, our dearest Dr. Anandeshwan sir, the energy behind IAP Thrissur branch and all the activities happening here and in our state. Dr. Anandeshwan sir, I welcome you to this meeting. Next, let me, with a lot of respect, welcome all the senior IAPians, senior teachers for this webinar. Then I should, with a lot of happiness, express my sincere love and respect to our dear President, Dr. Reddy Madam, and our very active Secretary, Dr. Srijit, and my love to our dear Itub sir. Actually, it's a great happiness once again to be in this webinar. Now, my duty is not complete if I not welcome all the members of our IAP fraternity. That is the spirit which is keeping us together all over the state, all over our country for this wonderful webinar organized by our very active branch. I should take this opportunity to welcome our senior members, Dr. Ravindra Verma sir, and who are coming, Manuel sir, Parvati madam, everybody who are actually guiding us to conduct this webinar. And last, let me welcome our ever-loving, ever-dearest, ever-enthusiastic, always a lot of knowledge to teach us, to lead us, always our dearest Jayakumar sir. I see sir itself, that motivation is there, that happiness to see you sir, to talk with you, to interact with you, to listen to you. I welcome you sir to this webinar. And I have not met Dr. Praveen, but I know from Government Medical College Thrissur, I know sir is a wonderful teacher with a lot of motivation, very active. I welcome you sir, Dr. Praveen, for this webinar of IAP Thrissur branch. Firstly, I welcome all members of IAP, all the teachers, all senior members, all PG students who are utilizing these webinars to gain knowledge. Thank you very much. Now over to our dearest Anandeshwan sir. Thank you.
So you're muted. Please unmute yourself. No, sir, you are not audible. Please unmute yourself.
Okay. No, it is okay. It is okay. So, very good evening. Respected President Dr. Rajesh Shantakumar, Secretary Srijit, and Vice President Dr. Sunil Menon, Professor V.K. Parvati Madam, Purushothaman Sir, and Past President Dr. Varma, State Vice President Dr. Mukesh, Senior colleagues, my dear friends. It is very happy indeed because it is our second monthly meeting of IAP Thrissur. We are organizing so many web meetings, but it is monthly meeting is second one. And so many programs. It is very happy to see that IAP Thrissur is organizing so many programs. Sunday they are conducting a totally different program in the form of charitable activity and also a national president. It was actually a national conference because national president, national secretary also participated. And also today we have a special day because it's the end of ORS day and the beginning of the breastfeeding day. Whether we'll observe it as a ORS day, breastfeeding day. So for that, the opt-in topic is probiotic and prebiotic. For diarrhea control, probiotic, prebiotic, I think acute diarrhea disease, antibiotic, and also diarrhea, everything will be mentioned by Dr. Ajay Kumar. Breastfeeding, it is the most lactobacillus abundant in breast milk. One reason why we have to give breast milk is there are so many bacteria, bifidobacteria, lactobacillus, everything is there in breast milk. So I think it is a very good topic selected by IEP Thrissur. Jayamasa is not a new person for IEP Thrissur. Even though he's not working in Thrissur Medical, he works in so many other medical colleges, Kottayam, Alappuzha, Trivandrum, and everything. I think I should not work in Thrissur Medical College. Anyway, at present he is working as HOD of the Amrita Medical College. He was past state president of IEP Kerala, NNF. And also he was past executive board member of a national IEP executive member. He was secretary of Allergy and Immunology chapter. He wrote chapters in so many textbooks. He had delivered talk in so many national conferences also. I think with a few introduction, I invited Dr. Jayaguma to talk on prebiotic and probiotic. Over to Jayaguma, sir.
Okay. Thank you, Dr. Anandakeshavan, for a nice word. Most respected National Vice President, Dr. Anandakeshavan, President of IAP Thrissur branch, Dr. Reddy, Secretary, Dr. Srijit, Treasurer, Dr. Itup, and vibrant Vice President, Dr. Sunil, all the senior stalwarts, V.K. Parvati Madam, and Dr. Vinod, Dr. Purushothaman, Dr. Ramraj, Dr. Kalyani, and my dear friend, Dr. Varma, and all the distinguished members of the IAP Thrissur. At the outset, I would like to thank Dr. Anandakeshavan, especially for giving me the chance to present this topic, the role of probiotics in pediatric practice. May I share the my screen?
Yeah.
Okay. So the topic for today's discussion is bugs as drugs in pediatric practice. Do you know this man? This man is responsible.
Slide setting not proper.
Okay,
Share the screen. Srijit, help you. Srijit.
Can you see it now?
No.
My God.
Pacha screen green.
Earlier, we have done it correctly, sir.
Pardon?
Green is the
Can you see it now?
No.
My God.
Please help me.
Can we help from source and
No problem of Srijit.
No.
How to? So I have pressed this share screen and then
Share screen. Share screen sir desktop. ഷെയർ സ്ക്രീൻ വരും. അപ്പൊ ഡെസ്ക്ടോപ്പ് കിട്ടും. അത് പ്രസ് ചെയ്താല് നമുക്ക് നമ്മുടെ പവർ പ്രസന്റേഷൻ കാണാൻ പറ്റും. ഷെയർ സ്ക്രീൻ അമർത്തിയോ?
അമർത്തി.
അപ്പോ സാറിന് ആ ഇത് കിട്ടുമല്ലോ, ഷെയർ സ്ക്രീൻ എന്ന.
Then I press the Baksa's drugs. Can you see it now? I can see, but you cannot see.
അല്ല, സാറിന് കണ്ടപ്പോ സാർ ഷെയർ സ്ക്രീനിൽ പോയിട്ട് സാറിന് ഡെസ്ക്ടോപ്പിൽ ആ ഡീറ്റെയിൽസ്.
Could you please help me? Oh, somebody is there to help me. Please.
Yes.
Can you see it now?
Yes, sir.
അപ്പൊ സാറിനും കാണാം, കുട്ടിയെയും കാണാം, രണ്ടാളെയും കാണാം.
Oh, my God.
എല്ലാവരും ചെയ്യും.
Okay. Can you see? Enlarge. Enlarge slides. Where?
സാറിന് ചെയ്യുന്നല്ലേ?
ചെയ്യുന്നതാണ്. പക്ഷേ ഇത് ഓക്കെ. സ്ലൈഡ് ഷോ.
സ്ലൈഡ് ഷോ മോളില്.
Okay. Okay. Sorry for the trouble. So, do you know this man responsible for this this probiotics? This man, his name is Eli Meshnikov of Russia. He is responsible for. Oh my God! Why it's not moving? Gayatri, it's not moving.
Stop and share once more.
Button. Stop sharing and once more.
Yes.
So what are probiotics? They are live non-pathogenic microbial preparations, and they colonize in the intestine and they provide beneficial effect to the host. So they are digestible food ingredient. So they facilitate the growth of intestinal bacteria. So that's the action of probiotic. They are fructooligosaccharides. If they act on the right side, they are short chain. Short chain act on the right side and long chain act on the left side. And combined short chain and long chain act on the entire colon. Example is inulin. So one of the most important probiotics are Lactobacillus, Bifidobacteria, Streptococcus thermophilus, and Bacillus cloacea and Saccharomyces boulardii. So what are the characteristics of this probiotics? They are human in origin. They are non-pathogenic. They retain the viability even after processing. You know that some of the substances are acid and bilabile, but they are not. They adhere to the target organs. So they persist in the GI tract. They have the property of antimicrobial substance production, and they influence the immune functions also. So in other words, a combination of prebiotic and probiotic is known as symbiotic. So Bifidobacteria plus fructooligosaccharides, Lactobacillus rhamnosus plus inulin, Bifidobacteria plus galacto-oligosaccharides. So these are the combinations. So these combinations acts on the entire colon. How do they act? They normalize the intestinal flora. They increase the mucosal barrier functions. They increase the immune defenses of our body. They have enteral nutrition properties. They increase the vitamin K productions. They have gut protective nutrients. What are the gut protective nutrients? They are arginine, glutamine, and short chain fatty acids. So this increase these substances and they decrease the pathogenic bacteria and they decrease the intestinal permeability. So they act by acidification, they act by competition with for nutrients and receptor addiction sites. They increase the IgA level. You know that IgA is very important. And they produce inhibitory substances like bacteriocins. And they reduce the pro-inflammatory cytokines. This is the mechanism of action of probiotics. So you know that so gut in colonization in preterm babies. So you know that, sorry. So in preterm babies, so sorry for this. So something is coming in between. Oh, I cannot remove that. So 70% is completed by 4 days. What are these bacteria? They are bacteroids, E. coli. These are the usual organisms. Then comes gram-negative bacillus. Gram-positive colonization happens only late. And examples are Clostridium is transient and even after 4 weeks. And if you use antibiotics early in newborn babies, this gut colonization is delayed. Again, it's not moving. Whether I have to do it again?
No problem, sir. It is moving. No problem.
It's not moving back here. Okay. It's not moving. Oh, okay, it's moving. Okay. No, it's not moving. Okay. Stop share. Sorry for the trouble. Hang on. Okay. Now let us see the gut microbiota of older babies. There are 300 to 500 different species, and stomach and small intestine contains only very little bacteria. On the other hand, large intestine contains very huge amount of bacteria, say 10 raised to 11 to 10 raised to 12. And you know that 60% of the fecal mass is because of fecal bacteria. And let us see the importance of the flora. And sterile gut is defective. How defective food tolerance. Sterile gut, poor response to infectious agents. Early colonization, better antibody response. And early lactobacillus colonization reduce the level of IgE. Now let us see what are the gut protectors. Exclusive breastfeeding is a gut protector. Gastric hydrochloric acid is a gut protector. And peristalsis of the upper gut protector. And most importantly, ileocecal sphincter. What are the gut destroyers? If you use your antacids like or PPI or sucralfate, or if you're H2RA, they are gut destroyers. Artificial feeding is a gut destroyer. Gastric stasis, gut destroyer. Intestinal resection definitely is a gut destroyer, and invasion by the pathogens. And there is what is the role of probiotics in allergy. Lactobacillus GG is very important to prevent allergy to milk. If you are given this Lactobacillus GG, there is less incidence of allergy in people. Lactobacillus GG may be effective in treating allergic disease if administered at birth and to pregnant women. So consumption of yogurt for a year reduces the symptom of nasal allergies among volunteers who consumed yogurt compared to people who didn't take the probiotic. They have a role in atopic dermatitis. So allergic infants have more Clostridia and fewer bifidobacteria. Hydrolyzed food quality can be improved with the Lactoraminosus GG. Supplementation to the expectant mothers are found to be relevant to reduce allergy in infants. How probiotics works to prevent allergy? They act by degradation and structural modifications, normalization of the properties of the aberrant indigenous microbiota, regulation of the secretions of inflammatory mediators, prevents food allergy by promoting endogenous barrier, reduction of serum IgE level, and most importantly, reduction of theta-2 cytokine response. And what are the use of probiotics in pediatric practice? So they have important role in the prevention of necrotizing enterocolitis. You know that necrotizing enterocolitis is an important problem in preterm babies. So they have important role in antibiotic associated diarrhea. They have a role in infectious diarrhea. They have a role in neonatal jaundice. They have a role in allergic disorders, as said earlier. They have a role in prevention of pseudomembranous enterocolitis and role in stress situations. So probiotics, the indications are antibiotic associated diarrhea, infectious diarrhea, travelers diarrhea, IBD, and prevention of colon cancer, improving the absorption of minerals in the intestine, pseudomembranous enterocolitis, and role in the prevention of Helicobacter pylori. So they have an extra-intestinal functions like lowering of cholesterol, prevention of cancer, improving the immune functions, and maintaining the urogenital health, and role in sick children in the PICU. Now let us see the NEC. So incidence is quite high. You know that the causes are immaturity, prematurity, impaired intestinal motility, and most important is prematurity, and intestinal ischemia, impaired liver functions. What is the mortality in NEC is quite high. So it's more than 30%. So the studies done in various parts of the world, like Colombia, that shows 50% reduction if you use probiotics in NEC. Another study in Italy that showed good response. low rate of incidence in a study conducted in Italy. In Jerusalem study, that shows probiotic group only 1%, but control group it is 14% in EC. And Taiwanese study that showed probiotic 5% with the 13% in the control group. So that's the importance of this probiotics in EC prevention. And antibiotic associated diarrhea that varies from 5 to 39%. It can be mild diarrhea or it can be toxic megacold or even to death. And what is the result? That cause prolonged hospital stay, economic loss, and you treat these patients with the metro, clindamycin, and third generation cephalosporins, or you may change to vancomycin and metro. But another option is to give probiotics in this antibiotic associated diarrhea. And probiotics have a definite role in antibiotic associated diarrhea by enhancing the natural barrier, modulating the immune system, and direct antimicrobial actions. They act on the enteric nervous system and regulation of the intestinal enzymes. So regarding coming to the infectious diarrhea, this Cochrane says that they reduce the severity of bacterial infections and ensure the diarrhea does not exceed to more than 4 days. And role of probiotics in diarrhea. So some other studies shows that they reduce the duration by 25 hours and reduce the duration lasting more than 4 days or more by 59%. Few diarrheal stools on day 2 after probiotic treatment. And probiotics in neonatal jaundice. Enterohepatic circulation is the most important reason for neonatal jaundice in so many cases. Even when you are seeing neonatal jaundice, even when there is no incompatibility, no RH, no ABO incompatibility. So why do they act? Because sterile gut, there is an enzyme known as beta glucuronidase. This beta glucuronidase deconjugate the already conjugated bilirubin, and then enterohepatic circulation occurs. If you give bacteria, you can prevent the action of this beta glucuronidase. Most importantly, you know that breast milk also contains beta glucuronidase. So as per the policy of the IAP, you are not supposed to give any feed to a child other than breast milk in the first 6 months of life. So probiotic Bacillus clausae prevents the action of beta glucuronidase by colonization. So this is the bilirubin metabolism that you know very well. So this is a study conducted and that shows the effectiveness of this probiotic. So this is a study things. This age and sex is comparable, and then you see the when in the intervention group 3.3% needed. The needed phototherapy is 3.3%, but in control group 6%. That is statistical significance is there 0.04. So there's a duration of phototherapy when given probiotics given and not given. So that means not given 50 hours of phototherapy needed compared to probiotic gives only 22 hours. So this difference in proportion of subjects requiring phototherapy was significant between two groups. And treatment with probiotic reduce the risk and need of phototherapy by 44%. This is the in neonatal group. Benefits: you can avoid blood sampling, and there is mother to child interaction. You know that the best time to increase the bonding is then immediately after birth. At this time, if the baby is away from the mother, baby is under intense light and intense heat, and baby is dehydrated, how much damage we are causing to these newborn babies. So, and reduction in the usage of blood products. We people used to treat these patients with IVIG, etc. Those you can avoid. Avoidance of all bad effects of phototherapy and exchange transfusion in some cases. And another situation is pseudomembranous enterocolitis, that we are using this probiotic. So there is history of use of antibiotics, non-bleeding diarrhea, extremely toxic conditions, pseudomembranes in the colonoscope. The colonoscopy you are able to see, and probiotics have significant role. Traveller's diarrhea. The organisms are Clostridium jejuni, Shigella, Salmonella, Enterotoxin E. coli, Enteroadhesive E. coli. So rotavirus, Astro, and Novak, and Giardia are other organisms, and they are present as diarrhea. And the treatment that we offer is Cipro, levofloxacin, or azithromycin, or rifaximin. And probiotics are useful adjunct in traveller's diarrhea. Inflammatory bowel disease. Bacteria that reduce inflammations and strengthen the host defense could be used to treat inflammatory bowel disease. Probiotics microbes could be the most successful treatment for IBD to date. Prevention of colon cancer. They found that Lactobacillus bulgaricus antimutagenic due to bind heterocyclic amines. So decrease the activity of beta glucuronidase. Decrease colon cancer in consumers who take fermented dairy products. Mineral absorption. They have some role to improve the mineral absorption. Helicobacter pylori prevention. This Lactobacillus salvarius prevents the colonization of Helicobacter pylori. Cholesterol lowering, it has some effect. Lowering the BP by action on the AC inhibitors. And Role in immunity, competitive inhibition with the pathogens, increase IgA producing plasma cells, increase phagocytosis, increase proportion of T lymphocytes and NK cells with the use of these probiotics. So it releases UTI and bacterial vaginosis in people who are taking these drugs. And this is lactobacillus acidophilus rhamnosus in acute diarrhea. No significant benefit as per one study. There are so many reasons for that. This study shows that there is not much benefit, but other studies shows there are effect. Significantly decrease the duration of diarrhea by 5 to 5.3 compared to 9.2 days. So there are certain unpleasant questions. Are we ready for probiotic treatment in newborn babies? Is it evidence-based? What is the dose? When to start? When to stop? Is it safe? Are we ready for probiotic treatment in preterm babies? Still in the early stages of understanding, you know that so many studies shows this effectiveness in necrotising enterocolitis. So combined strategies may be tapped in any like breastfeeding and probiotic. Questions are, is a single one is best or double or triple probiotic mixture is more effective? Has to be answered. Is it evidence-based? Systematic review of all randomized control trials are there for the use of probiotics in NAC in preterm babies less than 1,500 grams. And what's the dose? 10⁶ to 10⁷ colony-forming unit to reach the target site. Less than 32 weeks, median dose used is RCT in preterm is 3 into 10⁹, 1.5 to 10⁹ CFU. A starting dose till the feed of 50 to 60 ml per kg per day is reached. Dosing single dose better than divided dosage, maintain osmotic range of 246 to 320 in preterm formulas. When to start? As early as 4 hours before any pathogenic bacteria reaches the gut in neonatal jaundice to prevent hyperbilirubinemia, to be continued for a period of 3 days. So probiotics till 36 to 37 weeks to prevent NEC, and in ADD with the onset you have to start and stop as and when the symptoms are controlled. To prevent neonatal jaundice you have to use it for 3 days. Is it safe? No report of untoward incidents for many level 3 nurseries in Japan, Italy, Colombia using probiotics for decades and have not reported any adverse effects. Safety precautions: restrict the volume to 5 ml per dose, maintain cold chain, leftover portion has to be discarded, clinical monitoring for intolerance like diarrhea, flatulence, vomiting, and probiotic sepsis, inform parents about the benefits and safety profile, extremely rare adverse effects, including cross-contaminations. My dear friends, the carry-home message is that probiotics are an unconquered area. Wide scope for research, clinical application. Benefits may go beyond patient due to the herd effect. Reducing the neonatal jaundice by admission control disease, the burden, you know that burden, admission control disease, burden in the nurseries. You know that so many patients are admitted in nurseries only for phototherapy. They are not sick babies, they are well babies. They create trouble for the neonatologist. So thank you so much for the patient hearing. Any questions?
Vijit, I stop. So thank you, sir, for the wonderful session on probiotic and also in a limited time. So is there any question, Srijit, in the utmost?
Sir, one question, sir.
Yes.
Sir, now we have understood that probiotics is so important. It stands between the patient and doctor. So any disease, it has a role. Even prevention of cancer, autoimmune diseases. Any roles? Autoimmune diseases.
Whether it has a role.
Ah.
So the studies not that much regarding this use in probiotic. I have not come across. I have not used this in. So, but to tell you frankly, I am reluctant to use this probiotics in immunodeficiency state. So all other situations, I am confident to use this probiotic. But immune deficiency states, I am a little bit hesitant to use probiotics.
Sir, one more question. Ideally, when we should take the probiotic?
Which case? Which condition?
No, ideally before food, after food, or with the food, how to take the probiotic?
So they are not acid or bile labile. You can take on an empty stomach or after food, there is no problem.
Okay, sir.
Devama sir, there are two questions regarding. One
Okay.
is use of probiotic in immunocompromised immunosuppressant preterm baby. Even
That
though you mentioned the preterm baby, you mentioned it, and you said that you won't be very useful in immunosuppressant. That is true.
Studies are there. Well-conducted studies are there for use in preterm babies. But regarding immunocompromised babies, you should be very careful. But there's a chance that it may cause problem, especially with the Saccharomyces boulardii. There is history of sepsis.
So second thing is that one a clear indication which I mentioned is that the antibiotic associated diarrhea.
Yes.
So every time when patients, our patients are over treated with antibiotic, so all the antibiotic prescription, we are seeing this common indication also associated accompanied with this probiotic.
Could you please repeat? Could you please repeat?
Antibiotic associated diarrhea is one indication for you mentioned. Means it is the indication is the antibiotic associated diarrhea.
Diarrhea.
So
Yes.
the trend is that with every antibiotic, people are using probiotic and unnecessarily because we are seeing it is prolonged use, it is okay, but 2 5 days antibiotic, how it will cause any problem? And whether this probiotic, prebiotic, this gaseous one killed by antibiotic?
So that's a different question. Only if the diarrhea starts, I have told you that only when the diarrhea starts, you have to use probiotic. So there is no need of starting probiotic along with antibiotics. If
Yeah,
the
people are
diarrhea
giving
starts,
like that. Yeah, yeah.
that is not correct.
Any other serious adverse reaction? Allergy,
No,
something like that?
so in fact, I have given to this probiotic to more than 4,000 newborn babies. I have not seen any side effect in any of the babies. So my experiments, my knowledge is mainly with the newborn babies. I have given probiotic in 4,000 newborn babies in a span of 1.5 years, but none of them developed this problem other than this vomiting that occasionally, because when you give some baby, immediately they vomit. Even if you give oral polio, they may vomit. Only that much. Other than that, there is no side effects I have noticed.
So you are given it for neonatal jaundice or NEC?
And I have given for neonatal jaundice.
Purushottam sir, Purushottam, any comment? Srijit, unmute sir. Srijit, unmute Purushottam.
Or can unmute himself. That is the question.
Nothing more to comment. It's a good presentation, sir.
Thank you.
Thank you.
So one more question to Jayama sir. So
Yes.
what is the dosage according to the age, and is there any particular probiotic is superior?
That I cannot say, because in my experience, when I conduct my study, I have used only this Bacillus clostrae. The reason being that was the preparation available only in the sterile containers like a vial. So later other preparation has come. In our country, suppose if you ask them to mix with the water, then there's a chance for contamination. Fearing that, I have used the liquid preparation. Otherwise, I am not in favor of any particular probiotic. That when I conduct a study, I selected that topic because that time only this drug was available only in the liquid form and available in sterile containers. Suppose we ask them to mix with the water or milk, actually there will be contamination, and then the blame is on probiotic. So I don't want that. That's why I selected the Bacillus clostrae.
So Jayama sir, we have 2 senior neonatologists here. One is Dr. Ravindra Verma, one is Murali from Kodungalur.
Yes.
So may I get some opinion about jaundice? There are experience with jaundice and NEC, Dr. Verma?
Yes, sure, definitely. I appreciate. And Dr. Verma is a
Verma sir,
close friend of mine. I always appreciate.
unmute. Verma sir, unmute.
Vermaji's songs, that I am a fan of him.
And Murali also ready.
I have not so far given for neonatal jaundice. That is for a fact. My worry in giving newborns extremely preterm, because Australians, they say that they are giving it left and right, and many other places also they give it left and right. Our worry is that if there is a sepsis occurs, there is no possibility that we will be able to culture that organism if it is with the probiotics strain. The cultures will say some contaminant, so we won't have a proper culture positivity. That is the main worry. Otherwise, if you have facility to do that, give it. Fine. That is my take on that.
Murali is there. Murali from Kodungalur. Yeah, Murali sir.
Hello, sir.
Yeah, Murali.
Actually, I also have not used this probiotics for the prevention of neonatal jaundice. I'm very happy to know that you are using it. And can you tell me what is the dose of Bacillus clostrae you are using for?
This is 5 ml BD I am using, but 5 ml BD.
Okay. It's
So
useful
last comment from VK Paradi madam. Paradi unmute. Madam, Paradavale, Taidum, curd and yogurt. That is good, madam. In olden times we used to give yogurt, curd and everything. As a prebiotic like that. Madam, some comments about old food habits and this one.
Yes, always the old food habits are quite good. We use curd and curd, but I think yogurt has got the organism. What is the organism in yogurt? But Curd, you have mixed group of organisms. That's one problem. So for newborns, it will be always better to use probiotic rather than curd. It was a good presentation, Jay Kumar.
Thank you, madam.
Thank you very
madam.
much.
Thank you, madam. Thank you.
Okay.
Thank you, Jayuma. Thank you for
Okay.
keeping time. And
And
on behalf of the IAPA Thrissur, profusely thank you.
once again, I
Thank you.
thank you all. Once again, thank you all.
Now, next we'll have our speaker, Dr. Praveen.
Thank you.
Praveen is there? Dr. Praveen?
Yes, sir. Yes, sir.
So,
Yes, sir.
Dr. Praveen was with us for a talk around 1 year back about hepatitis A. I think we all are remembering that one in Casino Hotels. He had again a wonderful talk on hepatitis A. Praveen completed his MBBS and MD from Kozhikode Medical College and a DM from Trivandrum Medical College. And he's from my place, Kasaragod also. So, and also he was the IMA secretary of Vadakanjeri, then Gut Club president, then Liver Club secretary, and so many position, official position here. And also he had many publications in various national and international journals. He is at present he is working as associate professor of gastroenterology, Medical College at Thrissur. So another common problem is constipation. When we are studying MBBS or MD, constipation was not a problem because we are seeing more diarrhea and a very large diarrhea ward in the complete entire floor of IMCH in Calicut was occupied by diarrhea. No diarrhea ward is now the problem is constipation. We are seeing more cases of, even though it is a diarrhea week, ORS week, everything, we are seeing more cases of constipation than diarrhea. Whether it is changing food habit or sedentary habit of our children, or we are using more and more using Western closet. And of course, it is 90% anyway, it is functional only. So to tackle this problem, important problem, because patient will move from one place to one place and like that. And also one important thing is that they will stop the treatment advised by Thrissur. So importance of follow-up of the patient also very important. So to enlighten all this problem, we have an excellent speaker, Dr. Praveen. Praveen, over to Praveen Kumar.
Yes, sir. Just a second, sir.
Visible. Let's start.
Sir, okay, sir. Slideshow, I am waiting.
Clear?
Yes, sir. Yes, sir. So very good evening. Good evening to all, sir. At the outset, I thank the IAP Thrissur chapter for giving me this opportunity, especially the office bearers and that to my teacher Ananda Keshavan sir. As he mentioned, he is from my place. And before starting my talk,
Praveen, only central screen central central.
Yes, sir.
Which side la nikkunnu? Okay. Now it is okay. Wonderful.
Yes, sir.
Okay.
Okay, sir. Right, sir. And to talk, very familiar, I mean, very unfamiliar faces are there in this particular group. I am not that familiar, but to talk in front of Parvati Madam, Purushothaman sir, and Ananta Keshavan sir, all these three makes a deadly combination or dangerous combination for me to talk. First of all, this ORS week end, I'm there with the topic constipation. Constipation is a very common problem in nowadays pediatrics, including adolescents, because we are seeing more adolescents here in our department also. And regarding the constipation, as Ananda Keshavan sir told in the beginning, that previously we had acute diarrheal disorders or acute diarrheal diseases, and nowadays due to many problems, maybe because of some industrialization, the modernization, the food habits changing, and all other cultural habits, we are seeing more constipation patients in the pediatrics age group. And just a brief glimpse about the normal bowel habits in children. Bowel habits are the frequency, consistency, and size of the stool. The mean frequency of the bowel movements per day is maximal in the neonatal period and declines to once a day from the age of 48 to 72 months. The consistency, it tends to become harder as the child grows older. The breastfed infants pass more frequent and softer stools compared to formula feds. These are the basics before approaching a patient with diarrhea. And this is just a graphical illustration of the above mentioned things. That is, this is a newborn period, and this is the more towards adulthood. And this is regarding the consistency, and it's about 18 to 24 months. It's more towards formed stools. Definitions and terminologies. By convention, the constipation is. Please inform when I have to stop, because this is a boring topic. But with your interaction, we can make it more interesting thing. Definitions and terminologies. Conventional definition is difficulty and delay in passing stools, resulting in significant distress. We can classify this into acute, that is constipation less than 2 weeks, and chronic, when the constipation is lasting for more than 2 weeks. The constipation, it is not simply a duration. Suppose if the patient is not passing the stool for the last 2 or 3 weeks, so it's not a duration alone. We have to consider the following facts before analyzing the problem of constipation. So the definition of constipation is highly subjective, and it involves the stool frequency, stool consistency, and difficulty in passage of the stool. A soft stool every 4 days may be a normal thing for a person, or a hard stool, even a single day, may be abnormal. And in order to categorize, because there are so many confusions regarding the definition of diarrhea, how to approach, is it really a diarrhea? Suppose a patient is coming to, constipation. If a patient is coming with the constipation, sometimes just before your arrival, he or she may be consuming so many, say, meaty foods, or so raw foods, or baked foods, something like that. Can we include that into the criteria? So in order to settle all these things, we got so many criteria in the world, of which the 4 are very important. They are Rome, Ispahan, Boston, and Paris. Among these, the most practically approachable, which is applicable to India or Kerala or in our Thrissur, they are the Rome or Ispahan. Ispahan is, this is Indian Society of Pediatric Gastroenterology, Hepatology, and Nutrition criteria. The Rome 4 criteria for functional constipation. The constipation, in other words, we call it as functional one, because so many organic varieties are also there. That comes under a separate heading, even though we call it broadly as constipation. A diagnostic criteria for the functional constipation. It must include 1 month of at least 2 of the following in infants up to 4 years of age. They are 1, 2 or fewer defecations per week. 2, history of excessive stool retention. 3, history of painful or hard bowel movements. 4, history of large diameter stools. 5th, history of large fecal mass in the rectum. This is up to 4 years. And in a toilet trained children, the following additional criteria may be used along with this. They are at least 1 episode per week of incontinence after acquisition of toileting skills, and history of large diameter stools that may obstruct the toilet. And the 7th one is not very much applicable to our, say, Kerala's or Indian standards. This is according to the Western standards. And older children must include 2 or more of the following occurring at least once per week for a minimum of 1 month. They are 1, 2 or fewer defecations in the toilet per week in a child of a developmental age of at least 4 years or more. 2, at least 1 episode of fecal incontinence per week. 3, history of retentive posturing or excessive volitional stool retention. And 4th, history of painful or hard bowel movements. 5th, presence of large fecal mass in the rectum. And 6th, history of large diameter stools that can obstruct the toilet. After appropriate evaluation, the symptoms cannot be fully explained by another medical condition. And the Ispahan criteria of chronic constipation, the duration, it is applicable to, it's very simple, applicable to all the ages. Duration of more than 4 weeks and presence of more than 2 of the following 6. 1, defecation frequency less than 2 times per week. Fecal incontinence more than 1 times per week after the acquisition of toileting skills. History of excessive stool retention, and history of painful or hard bowel movements. Presence of large mass in the rectum or per abdomen on examination. History of large diameter stools that may obstruct the toilet. Just a word about fecal incontinence. Fecal incontinence is defined as passage of stools in the undergarment. For this discussion, we are important for constipation associated fecal incontinence, not that much about non-retentive fecal incontinence. What is refractory constipation? Constipation not responding to optimal conventional treatment. That is for at least 3 months of treatment despite good compliance. How common is constipation? 5% of the, all of you agree that 5% of the general pediatric office visits are due to constipation. 25% of all referrals to pediatric gastros are due to this constipation, and its prevalence is 0.7 to 30%. By means of chronic constipation in pediatrics, unless proved otherwise, it is functional. Of course, innumerable causes are there, broadly divided into surgical and medical, amongst which the important ones are surgical, local anal pathology, Hirschsprung's disease, anteriorly placed anal orifice, spina bifida, meningomyelocele, and the medical drugs. Especially, we must be very, very careful because many of the pediatricians, the GPs, many of the GPs are using to treat this constipation antispasmodic, say dicyclomine. Mind you, in many conditions of chronic constipation, if it is long lasting, many children will be complaining of abdominal pain. So thinking that this abdominal pain may be relieved by antispasmodics, we will be giving this dicyclomine preparations. This is one of the most common drugs which is prescribed for this condition, which can precipitate a constipation. Next is mental retardation, hypotonia, tethered cord syndrome, hypothyroidism, hypokalemia, and hypercalcemia. This I'm not making you say a boring one. This is simply the pathophysiology. I can skip this slide for a want of time, and this is very important. In the constipation, as you know, the stools are stored in the sigmoid column, and thus below that the puborectalis muscle is there, which is called the so-called muscle of continence. Normally, it is maintained, say, forming a puborectalis angle of around 100 degrees, like that. And if you are sitting for toileting purpose, that particular angle becomes lost and it becomes a straight line, so that the evacuation process is made easier. And what happens if you are making a sitting posture, say, to maintain the continence of the puborectalis muscle in the sitting posture, and there is this produces a choking feeling for the rectum, or just beneath that sigmoid column where it is stored. In the squatting position, that particular angle is lost, and the squatting relaxes the puborectalis muscle and straightens the rectum. This is very important in analyzing that so-called neurological involvement of the gastrointestinal tract, especially the pelvic floor dysfunction, pelvic floor dysarthria, evacuatory disorders, which are not uncommon in pediatric practice. Many of the seniors will agree that the ideal posture, that's a good old Indian tradition, the ideal posture for defecation is the squatting position with the thighs flexed upon the abdomen. The squatting on the floor is actually the most scientific way of doing it. By sitting on the European commode, you are only blocking your colon and aggravating the problem, as the puborectalis muscle will contract and choke the rectum. The precipitating factors. This premature initiation of the toilet training. All of you are very good masters in regarding the say growth and development, so I need not elaborate on much. The premature initiation of toilet training, drugs and intracurrent illnesses, quick and abrupt transition of diet, that is from liquid to solid or breastfeeding to bottle feeding, and change in the local environment, the start of schooling, psychosocial factors. This is just a glimpse of that. Intentional subconscious withholding of the stool. So this is a sudden change in the stool consistency that can lead on to infrequent stools, produces anal irritation, and due to the local problem, fissures and painful defecation. And this one is a very common problem which we will not be able to understand unless we are taking the history very correct. The toddlers usually cross the legs, stand rigidly upright, or squat quietly for defecating purpose. This produces distension of the rectum and to accumulate more fecal contents, and the urge to defecate goes off, and the particular pathology or the pathophysiology goes on. Just the in the age group, what are the reasons? The toddlers and preschool children, stress of beginning toilet, I'll make it fast. Stress of beginning toilet training too soon, fear of having accident and being reprimanded, stress of having a bowel movement on cue, fear of unpleasant or painful defecation. School age and adolescent, embarrassment of using public restrooms, reluctance to interrupt a playtime, feeling too busy, a fear of unpleasant or painful defecation, change in routine, or stressful life event. A consequence of chronic constipation, the fecal soiling, non-specific abdominal pain, rectal bleeding, urinary symptoms, nocturnal or enuresis, and school absenteeism. In this juncture, I want to mention one very, very, very important point, which is a very, because many of you have encountered the problem either in your clinic or as a referral clinic. There is a condition called solitary rectal ulcer syndrome. So in which the solitary rectal ulcer, majority of the condition in Thrissur Government Medical College Gastro Department, we are seeing adolescent boys and girls. They usually present with profuse mucoria, And from the local hospital or local clinician, they will be usually getting some so-called preparation for loperamide or laxative preparations or local anti-hemorrhoidal preparation like that to control this thing. Because in many of these children will be extremely tense, worried, anxious, or definitely there will be some psychosocial component behind that. And if you are eliciting the history, which we are using because we are working in a very limited resource center now, we are using that particular. That's if we will be getting the history of fingering to evacuate the bowel movements to a tune of say 70% of the cases, which we are finding it very useful. After taking this particular history and we are giving this clue to the pathologist, the HPR will very peculiar histopathological features will be there for SRUS. It's a mimicker for Crohn's, it's a mimicker for granulomatosis, tuberculosis, it's a mimicker for this neoplasm. We had 2 cases referred to us to rule out neoplasm rectum, but histopathology report came as solitary rectal ulcer syndrome. This is just a repetition, but just a perpetuation also. A toddler and preschool children, the stress of being in the toilet too soon, fear of having an accident or being reprimanded like that. Then history taking. In all age groups, I'm sorry for that, history taking in all age groups, the patient's family definition of constipation, past and present treatments, medications, family history, appetite, dietary history, you are familiar with all these things. And infancy, timing of first meconium, change from breast milk to the formula, blood in the diaper or in the stools, presence of abdominal distension. Toddler and preschool children, timing of first meconium, psychosocial, daycare attendance, withholding behavior, toilet training experience, like that. School age, same thing, right? This is we call it as the modified Bristol stool chart. Many a times in the pediatric gastro as well as in gastro, this is asked as a short question. This is nothing but the patient, this is patient friendly chart. This is to narrate or to illustrate the pattern or the form of stools or what type of stool they are passing right from the pellet, the so-called hard to the watery. 7 grades are there, and which is not many a times is not that much applicable in Indian subcontinent because our patients are not that, because the moment we are showing this particular table, they will be laughing at us. And this is the Brussels infant and toddler school scale that they're aiming the parents, especially mothers, to describe what type of stool the child or the kid is passing. Then the dietary history. Here onwards, we are going to the topic. History of intake of fruits, vegetables, and refined foods, as a bakery foods, beverages, etc. in older children. Nature of feeds, breast versus formula feeds, and details of supplementary feeds in younger babies. Exclusive and prolonged milk intake with a minimal solids in young infants, a major factor causing functional constipation in India. Calculate the dietary fiber per day. In older children, the rough formula is just age in years plus 5 in grams. Age in years plus 5 in grams. The physical examination. That in limited resource area, we are giving much importance for this. Should explore the severity of constipation and potential causes. Growth chart. The perabdominal examination, tenderness to palpation and presence of fecal mass. Perianal examination, skin tags, fissures, and anal appearance and the location of the anal orifice, which is very important. It's not uncommon in our area. We are seeing, I've seen 2 or 3 cases in the last 1 or 2 months. Physical examination. External anal inspection can assess the anal atresia and external hemorrhoids. It may also be used to assess a sphincter tone visually or identify the fecal material around the anus or in the underwear. In addition, examine the back for sacral dimples or spinal deformity. This is very, very important for postgraduate to analyze, both for gastros as well as in pediatrics. Assess the lower extremity motor tone, strength, and deep tendon reflexes can indicate whether additional assessment of neurological pathology is indicated. Digital rectal examination, you all know this importance, very, very important. It is helpful to diagnose the presence of fecal impaction, diagnosis of Hirschsprung's disease, and sacral mass lesions. It is recommended in the following instances. It is recommended in the following instances. Red flags, which will come in the coming succeeding slides. Red flag symptoms or signs. Onset of less than 6 months of age duration. Non-responders despite good compliance to therapy, and patients presenting with fecal incontinence to differentiate between constipation related and non-retentive incontinence. The red flags, which we are to give importance. Constipation starting extremely in the early life, passage of meconium for more than 48 hours, failure to thrive or anemia, absence of withholding maneuvers, bilious vomiting and abdominal distension, empty rectal ampulla on digital rectal examination, abnormal neurological findings, developmental delay, recurrent lower respiratory tract infections. The functional constipation is a clinical diagnosis. So very much investigation is needed if you are eliciting the history and clinical examination thoroughly. Feel for any abdominal lumps, digital rectal examination, and in this functional case, only less than 5% need investigations. Also strain for hypothyroidism, barium enema, especially for motor and muscular related mucosal abnormality, anorectal manometry, rectal biopsy, especially in Hirschsprung's disease and all. And coming to the management of functional constipation. Education, that's the most important thing and least stressed thing. Education, behavior modification, diet modification, disimpaction or cleaning out of the stools, prevention of reaccumulation of the stools, withdrawal of the treatment. Education, explain the physiological basis of constipation and soiling. Never blame the child. If there are any precipitating factors identified, it should be eliminated or modified by appropriate advice like counseling and all. Need for long-term drugs and regular toilet pattern has to be advised. Avoid antispasmodics and antidiarrheal drugs for pain and fluid fecal soiling. That stresses the importance of antispasmodics and antidiarrheal agents in this particular. Without a diagnosis, I mean. Optimum dose of laxative is unpredictable, so we have to titrate it. So need for frequent reviews initially. Behavioral modification, desensitization to the toilet. Scheduled toilet sits can occur 20 to 30 minutes after the meals. Toilet sit should generally last 5 minutes. Child's feet should be on footrest. Positive reward, develop a regular habit. And this toilet sit should generally last for 5 minutes. This is a very common complaint in our clinic, in our gastroenterology OPD. Those toddlers, adolescent children who are presenting with hemorrhoids and SRUS. In this particular history, they will be reading, they will be in a habit of reading over the toilet commode for say hours together. Toilet training. You all very well versed regarding this, should not be started before 24 months of age. The recommended age of training is between 3 to 4 years. This is roughly rule of 1. If we are giving the toilet training to the child or the infant, or say at 24 months, it must be one routine. That is especially 5 minutes after each major meal. It should be in one place, by one person, by using one word for say 40, something like that. In a child with constipation, make the child sit in the toilet 2 to 3 times a day for 5 to 10 minutes after meals, say within 30 minutes ideally. Make the defecation painless by treating anal fissures if it is present. Sit in squatting position in Indian toilet or with footrest in English toilet or potty seat to have appropriate angulation of the knees and thighs to facilitate expulsion of the stools. Reward system, that is positive reinforcement techniques, helps in motivating the child and also avoid the child-parent conflict or parental disharmony or parental misconduct. The dietary modification, encourage breastfeeding, cereal supplementation after 6 months of life, plenty of fluids, reduce milk, dairy products and soft drinks and bakery products, biscuits, bread, etc. Avoid junk foods like chips, kurkure, Maggi, burgers, pizza. Nowadays, the modern children are very much fond of these food products. High fiber diet, that is age in years, plus 5 grams, that is cereals, four pulses, bran, vegetables, salads, and fruits. Diet changes need to be permanent. And of course, family involvement must be there. The rough calculation for a fiber content of the diet. I am an inferior person to talk about this thing in front of the august audience like this. One fruit of 100 gram is equal to 2 to 3 gram of fiber, or one fruit of 200 gram, just the double amount. And here 50 grams of green leafy vegetables, that will roughly is equal to 4 grams of fiber. Disimpaction or clean out. Decompress the rectum. Re-establish the normal stooling pattern of the child. Prevent fecal soiling. High dose of oral laxatives, enemas, or manual disimpaction. How we can do this disimpaction or the clean out? Preferably in the hospital setting, that because of in particular era, especially the COVID area and COVID era and all, there are limitations for that. Preferably one-time hospital based. It has got 100% success in so many meta-analysis studies, and home-based in split doses, it has got even up to 97% success only. Oral route is preferred than other routes. It is non-invasive, better patient's acceptability, cleanse the entire colon, and equally effective as rectal disimpaction. Rarely only rectal enemas need as a supplementary therapy to clear the heavily hard-loaded colorectal region. Manual evacuation of rectum is rarely required in patients failing oral and rectal disimpaction, but it should be performed under anesthesia if at all necessary. Disimpaction or clean out. The preferred agents as per the recommendation, the number one recommendation is for polyethylene glycol solution. And it's a preferred method via oral route. At home, 1 to 1.5 gram per day in 2 divided doses for 3 consecutive days usually normalizes the pattern. In hospital, 25 ml per kg oral or nasogastric tube in young children. The endpoint is creal rectal effluent. Younger children may require intravenous fluids to maintain the hydration. Disimpaction or clean out. Rectal agents, enemas, that's saline and phosphate enemas, once per day, that's a dose. Maintenance therapy. Complete daily emptying of the lower bowel and to prevent fecal incontinence and abdominal pain. It should be individualized. The pattern of bowel movement, everything is individualized, because we should not stress unduly that a particular child should go or must go to toilet at 8 a.m. sharp or 8 p.m. sharp, something like that. He has got his own patterns, and we have to individualize the treatment. Titrated to achieve at least 1 or 2 bowel movements every day. The maintenance therapy, which is important. Osmotic laxatives, it's the mainstay of maintaining therapy in children. Draws water into the stool, thereby making the stool softer and easy to pass. 2 important osmotic agents are polyethylene glycol and lactulose or lactitol. The maintenance therapy, polyethylene glycol, 0.5 to 1 gram per kg per day for more than 12 months of age. It is not recommended below 1 year, that's why. Bloating, abdominal pain, cramps, and vomiting is self-limiting. These are the important minimal side effects, safe for both short and long-term use. Other agents for maintenance therapy, disaccharides, lactulose. Lactose is a combination of 2 molecules of galactose and fructose. It is non-absorbable synthetic disaccharide. It undergoes fermentation in the colon, it produces short-chain fatty acids, carbon dioxide, and hydrogen. The dose is 1 month to 12 months, 2.5 ml BD, 1 to 5 years, 2.5 to 10 ml, and 5 to 18 years, 5 to 20 ml BD. This is rough assessment. Of course, that rates according to the patient's requirement, and titration has to be individualized. The minimal side effect is abdominal discomfort or distension. Other agent is lactitol, which is a combination of lactulose and galactose and sorbitol. It's a monohydrate. The dose is 250 to 400 milligram per kg. Lactitol is more palatable than lactulose. The maintenance therapy, PEG is the first line of the polyethylene glycol, is the first line of therapy and is more effective as compared to lactulose or lactitol. In children less than 1 year of age, the only drug recommended is lactulose or lactitol. In case of non-response or intolerance due to non-palatability of polyethylene glycol, the second line of treatment is lactulose or lactitol, which is safe for all ages. Two osmotic agents like PEG and lactulose or lactitol should not be given simultaneously. Similarly, the combination therapy also has to be avoided. Stimulant laxatives used only as a rescue therapy. Otherwise, it's not recommended. An acute or sudden episode of constipation while being on regular complaint maintenance therapy, given for a short duration of around say 2 to 3 days to tide over the acute crisis of constipation, and then as we stop and move on to other drugs like say PEG and lactulose or lactitol. Stimulant laxatives in rescue therapy, the bisacodyl. Bisacodyl, it acts by stimulating the colonic motility, promoting the secretion and inhibition of absorption of water and electrolytes. Oral effect in 6 to 8 hours. Single bedtime dose, that is 3 to 10 years, 5 mg per day. More than 10 years, 5 to 10 mg or ml per day. It should not be used in children below 3 years of age. Definitely, it should not be used below 1 year. Not absolute contraindication. Rectal effect within 30 to 60 minutes. At 2 to 10, it's 5 mg. More than 5, it is 5 to 10 mg. The side effects, short-term usage is free from side effects. Abdominal cramps, diarrhea, hypokalemia, proctitis on prolonged use. It is contraindicated in children with the proctitis or anal fissure because it's heavily irritating. Sodium picosulfate. It acts as active metabolite that's produced with the bacteria, and it increases the peristalsis of the gut. Given as the OD dosage, that's for 1 month to 3 years, 4 years, 2.5 to 10 ml per day, 4 to 18 years, 2.5 to 20 ml per day. And the side effect, important side effects, abdominal pain, nausea, and diarrhea, to the tune of 50%. It is contraindicated in proctitis and gaseous abdominal distension because we may mask the underlying intestinal or pseudo-intestinal obstruction like paralytic tears or Gilbey syndrome like that. It's available as liquid. Just a word about withdrawal of treatment and follow-up. Reduce the dose of laxative only after stool pattern has become normal. A stool diary is very helpful. That has to be given to either father or the mother, especially to the mother who is with the patient always. No abrupt stoppage of medications. Ensure that a fecal impaction does not occur. High fiber diet to continue as in the prescribed dosage. Toilet training continue for 2 to 3 more years. Review. Initially weekly for 2 to 3 weeks, then monthly till stooling is normal, and finally bi-monthly for 6 months to a year. Successful outcome of treatment. Stool normalcy while on laxatives for a period of at least 4 weeks of initiation of therapy, and achievement of stool normalcy for a period of 6 months before tapering, or normalcy of stool should be defined as daily, not hard nor loose watery stools with the absence of pain, straining, bleeding, posturing, or incontinence. And what is refractory constipation? We had a just glimpse in the beginning. Premature withdrawal of laxatives, lack of compliance or education of the parents, lack of adequate and proper toilet training, wrong diagnosis. There lies the importance of making a very rigid diagnosis in the initial period. That's why the very thorough history taking, clinical examination, including a detailed neurological examination and a local examination, which is a must. We are for most forgotten artists doing a digital rectal examination. Especially last time, one of the examiner asked to one of our MD residents, we should not make it public, that sincerely tell me, are you in a habit of doing the per rectal examination routinely? The sincere answer was no. The first time that particular candidate was doing the rectal examination was at the time of university examination. slow transit constipation or the rectal dyskinesia or motility disorders. The carry home messages: functional constipation is the most common cause of constipation in pediatric age group. Most need only good history and physical examination, and thereby avoiding sophisticated investigations. Remember to differentiate functional from organic. Investigations are very rarely required. Assess the need for disimpaction. Initiate early treatment. Education of the family and counseling. Continue for months or years before deciding on withdrawal. And thanks for the patient listening. And if there are any mistakes I committed, please excuse me for that. It's open for any queries. It's open for discussion.
Stop sharing screen.
Okay, sir.
Praveen,
Okay,
stop
sir.
screen sharing. So Srijit,
Stop.
So actually, I'm inviting Dr. Jay Savai to address the given deliberation.
Thank you, Dr. Srijit, sir. Thank you, everyone, and good evening to one and all. And on behalf of our company, JB Chemicals and Pharmaceuticals Limited, I, Dr. Jay Savai, would first of all like to take this opportunity to thank all the IIP members for making this scientific event so successful. And it's indeed a privilege for me to be present here virtually, although not physically, with the stalwarts from the field of pediatric medicine. I think we as a company, we first of all like to salute each one of you for your tireless fighting spirit to fight this current COVID-19 pandemic situation, for your continuous hard work and support. And I would really like to extend my warm gratitude to IIP Thrissur for giving us this opportunity and this web-based platform for scientific discussion. With special thanks to Dr. Rati Santakumar, sir, the IIP president, and the Dr. Srijit Kumar, sir, the IIP secretary. And would even thank our honorable speaker, Dr. Praveen Kumar, for taking us through the session on constipation in children. I think, sir, your session was really very informative, right from understanding what is constipation, how to define it, how to really understand different therapy aspect. And really, your topic was really very exhaustive and lucid. And would also like to thank our moderator for today's session, Dr. Ananda Kesavan, for wonderfully moderating the session. Thank you so much, sir. And I think really would consider myself fortunate enough to be present here and to discuss in detail one of our very important and pioneer brand that we have just recently launched into the market, named Laxolite, that has been used for pediatric constipation. So I would just take a couple of minutes of all of you, and would just like to share some basic slide set, and would like to just brief you about our products in just a couple of minutes with all of you. So we have just recently introduced our brand named as Laxolite, which is nothing but polyethylene glycol 4000 brand, which is currently available into the market. We have just recently introduced. So why we have launched the Laxolite? So just would like to just give you a brief discussion. I think sir has wonderfully explained constipation, and it's a very common problem which I think most of all the pediatricians would be encountering when it comes to the functional constipation, especially in cases of children falling into the age group of around 2 to 4 years of age. And sir has beautifully explained the management of constipation, how important it is, and how important it is to treat the patients so importantly. Otherwise, there would be recurrence. There would be you'll see that there are a lot of frequent you'll see visits of refractory constipation cases as well. So I think laxatives which have been commonly prescribed by pediatricians, and as sir has already mentioned about polyethylene glycol macrogols, which are currently the gold standard, which has been prescribed by all the pediatricians. I think left, right, and center, almost all the prescriptions which we see is like polyethylene glycol has been very frequently prescribed, and sir has beautifully spoken about polyethylene glycol. And currently I think 3350 is the molecule that is currently been prescribed by almost all the pediatricians. But I think when we did a small survey amongst all the pediatricians, and when we spoke to some of the doctors, some of the parents, some of we came to know is that when we are talking of polyethylene glycol,
sir, how many times to take? We have a lot of question waiting. So how much time to take?
Sir, just 2 minutes, sir.
Because a lot of questions are waiting. Speakers waiting.
Yes, yes. Sir, actually, we have just launched polyethylene glycol 4000. So just wanted to showcase some of the benefits of polyethylene glycol 4000. So it's a liquid formulation. It's a better pediatric acceptance. You will see It's a ready-to-use formulation. So 3350, you will see that you need to dilute it in water, 50 ml to 100 ml. So here in 4000, you don't have to dilute it. You can use it as it is since it's a ready-to-use formulation. It can be mixed with any beverages. It has got a better taste as compared to 3350, does not require much dosage adjustment, no electrolyte loss, and it has been approved for 6 months of age onwards with extensive clinical data. And we have launched this particular product in the market in 2 pack size, 100 ml and 200 ml pack size at cost of 170 and 260 rupees. And it's sugar-free, sodium-free, water-soluble, colorless liquid that we have launched. And the dose, as you can see, it's 0.3 to 0.7 gram per kg per day for maintenance and 1 to 1.5 gram per kg per day for disimpaction. And you can see that, in case of 1 to 4 years of age, the volume of administration is very, very less. It's hardly around 1 tablespoonful or 2 teaspoonful that you need to administer to the smaller kids. So I think the compliance is the factor. Adherence to the therapy would be much better as compared to 3350. And plus, it's been recommended by guidelines like IAP, as well as Asfagen and Nasfagen for treatment of children. And it's also available in across more than 23 countries. So overall, if I have to highlight, it's a liquid formulation. So better taste, better acceptance, sugar-free, sodium-free, requires no dilution. So you can use straight away. You don't have to dilute it. And it can be mixed with any beverages like milk, water, fruit juice. And it has got fewer side effects as compared to 3350, where you see more electrolyte loss that has been seen. And it's been also approved by IAP, Asfagen and Nasfagen. And it's also available globally in more than 23 countries. So thank you so much. And thank you, IAP Thrissur, for giving us this platform. And I do request for your regular prescription and support for a brand Laxolite, which is polyethylene glycol, a newly entrant molecule in the market, which is a ready-to-use oral liquid formulation, which is sugar-free and sodium-free. Thank you so much. Thank you, sir.
Thank you, Dr. Jayasevan. Thank you. It is a wonderful presentation. And now we move to question session. Dr. Praveen, are you ready?
Yes, sir. Yes, sir.
So many questions are waiting for you. Two things are there because we are not very much, even though we are pediatricians seeing up to 18 years of age, we are not seeing much children above 12 years of age. So what are the common problems in adolescent reason for the constipation? Is it what toilet training or something like that? What is the common cause for in adolescent?
Yes, sir. Actually, I have already illustrated this particular thing in my slides. And the most important cause, especially we are getting patients from say 8 years onwards for this constipation. There's previously mentioned SRUS, IBS related constipation, all the, suffering from either anxiety disorders, say some so-called parental disorder, parental disharmony, or family conflict, or the school, something like a school problem. And last time, since you have asked this question, I'll narrate one history. One particular girl was brought to the gastroenterology OPD with the constipation. And actually, in fact, by taking the history in detail, actually that was a victim of child abuse. And I just exchanged the patient to the psychiatrist, and a police case was charged because the psychosocial and psychosomatic problems are so rampant in our area even now, even though we are claiming this our Kerala as the most literate state in country. I mean, it's a pathetic situation. We are seeing so many patients, so many patients.
What about the use of a repeated rectal suppository? Because people are using repeatedly, sometimes they are repeatedly using this one. And what is the use?
Exactly. Repeated rectal suppository, ideally we have to discourage that. Why? Because especially if you are doing it particular thing in a very young age group, because definitely that will going to the cortical sensation, cortical pathway of the constipation or the so-called defecation reflexes, and the brain will be getting adapted. Then there will be a tendency, and the studies has proved that there will be a tendency to move the fecal matter only if we are getting this particular, say, the suppository or something like that, especially a young child. And otherwise, if we are using this particular rectal suppository, it is not advocated. And in many cases, as one of the questions I can see in the chat box, one of the questions was an IBS related thing. One of the most common cause of constipation is IBS, that is functional constipation, either constipation variety of IBS or the IBS-M, that is alternating constipation and diarrhea type, in which one peculiar, because this is a very important complaint by the parents, the motion which is passed first will be very difficult or hard in consistency, and subsequently it will be semi-solid, liquid, and thereby watery. The only diagnosis is IBS, constipation, or alternating constipation and diarrhea type of this. So in the initial period, we should not show much enthusiasm for that, say, frequent use of rectal support. That has to be, it has to be used only in case of a crisis or in an emergency.
So Srijit, read some questions from the chat box. Meanwhile, I ask one more last question to Praveen. Because anyway, everybody is mentioning about the Western oil is harmful for the Indian children. So any modification, because gastro society is there, liver society is there, pediatric society is there, can we advise the manufacturer to prepare one suitable for our children? Some modification with the Western system.
Right. Yeah, we can suggest, sir, because as in the beginning I told you, as a part of industrialization, modernization, and a change of cultural habits and a very busy lifetime, we are forgetting about our common needs like this. And in this juncture, in the European toilet, the footrest, I told you, the angle of the puborectalis has to be the straight line. So while sitting on the commode, we have to elevate at the knee joint level by keeping a footrest, say approximately 1 feet or 1.5 feet, like depends on the height of the individual, so that the puborectalis muscle is relaxed, abdominal muscle is relaxed, it will be getting adequate contraction so that it is working as a stimulation for defecation.
Please ask some questions. You can read.
One more questions in the chat box. So what is the indication to start drug treatment in functional constipation? So after the behavioral modification and all, when is the time to start drugs in functional constipation?
Yeah, obviously it depends on the need. Suppose if the patient is responding to the so-called behavioral modification and education and all that, we can wait. Suppose if there is an emergency, definitely drugs are indicated. Or after sufficient waiting period, say around 3 months, if the patient is not improving, definitely drugs has to be started. No doubt. So an emergency situation is different. Like say the child may be in the exam time or in that say some festival season or something like that, on a travel.
Continuing on that question, if the child is asymptomatic for a new onset of constipation or a asymptomatic child, how many days we can wait till we can intervene with some kind of drugs for a new onset?
Yeah, if the patient is asymptomatic, watch for any red flags or any warning signs, something like that, because that need not be complained of. No, if the patient is asymptomatic, if there are no warning signs, if there are no harms, that means definitely some. If you are identifying definitely some problem with the feeding habits, if it is a small child or an adult or adolescents, definitely some problem with the either psychosocial background or the food habits. We have to correct that.
Sir, can you suggest any particular days? Because the parents are, after 2 days, the parents may lost 2 or 3 days, parents will start for rectal supposed to.
Before coming to OPD, that means definitely there will be parental anxiety, no doubt about that. That means it's for them, it's a need. For us, we have to wait whether it's a real need or it's an emergency. In both the situations, we have to start the patient on listening, because they are coming, definitely they will be trying so many so-called home remedies like say Nellika juice or that Kadaka, Tanika, Nellika, something like that in our OPDs. Even after failing that, they will be coming to our OPDs. Then Nellika juice is a very frequently used this thing.
Any laxative harmful to because any new laxative harmful to children?
Sodium picosulfate, definitely if you are in our busy OPD and all, if you are prescribing sodium picosulfate, we have to rule out a local pathology, number one, and local pathology, and also a systemic disease like an intestinal obstruction or a pseudo-intestinal obstruction or a paralytic ileus. We should not give unless we are not sure about that the bottom part. And suppose it is also, it has contraindications, sir, because suppose a patient is having anal fissure or fistula or any erosion of the epithelium or the mucosa in and around, say, anus, definitely it will be irritating.
Again, one question come for, what is any home remedy, the workable home remedy for constipation?
I mentioned it now that Kadaka, Tanika, Nellika, and this the so-called what is Nellika juice, everything is very good home remedy. But being a modern medicine people, we should not advise that. Why? Because there are so many papers, especially in our part, in Calicut Medical College also. This particular local, this say so-called Nellika juice or Kadaka, Tanika juice, they produce some form of gastritis. If you're taking it orally, gastritis, enteritis and colitis. And Professor Varghese Thomas sir has had a beautiful paper on regard this. One is regarding soap colitis. We are giving soap enema for that. Soap colitis and this Kadaka, Danika, Nellika. We should, as a scientific community, we should not allow this pudding. Other than plenty of fluid intake and good juice intake and green leafy vegetables and other food items which I mentioned previously.
So thank you, Dr. Praveen, for the wonderful presentation.
Yes, sir.
For
Thank you, sir.
formal voter thanks, I invite our secretary, Dr. Srijit, to propose voter thanks.
Thank you, sir. Before concluding our session, I would like to make an important announcement. But we have a very important panel discussion coming up tomorrow with the same platform, but at 7 p.m. tomorrow, because currently we are celebrating the breastfeeding week. So we have an important panel discussion moderated by our own Dr. Murali Raj, and a panel of experts will be following. And regarding today's session, I thank all the faculty, Dr. Praveen Kumar sir and Dr. Jaykumar sir, for coming to us and to give a wonderful and very elaborate and beautiful talks. And thank you, Praveen sir, and thank you, Jaykumar sir. And also thank Anandavashan sir for moderating this session wonderfully well. And I would thank the other office bearers of IAP Thrissur, Reddy Madam, as well as the Sunil Menon sir, for welcoming us. So thank you all for joining us, and I also thank the pharma company, the JB Chemicals, who have supported this our academic activity.